Hi, welcome back everyone to the afternoon session. It's my privilege to have three experts panel sessions to start us this afternoon. Some of you would have heard Claudia and Seb's talk earlier, but some of you might have gone to the other sessions. I think we would like to start with the brief introductions. So Professor Claudia Cooper is a professor of psychological medicine in Wolfson's Institution of Population Health, and we heard about her approaching studies earlier. Dr. Seb Walsh is a public health doctor and dementia researcher working at the interface of public health research and policy in Cambridge. And I'm very much interested in your idea of this kind of coupling a life cycle course of how to actually encourage the dementia talk and dementia prevention. And welcome to Joan. Joan Viskant. She is a registered nutritionist. I can't say that word. Sorry. And with the British Association for Nutrition and Lifestyle Medicine, and the registered nutritional therapist with the Complementary and Natural Healthcare Council. And you have given quite a lot of talks around councils. So basically, we got three experts, panel members who are very happy to take your questions. So we might have a quite spontaneous questions also coming from the audience. But what I would like now is start off with a brief introduction for each panel members. So welcome, Seb, if you could introduce yourself.
So my name's Seb. I'm presented earlier on for those who are in the room. I'm a public health doctor and researcher, and I'm interested in public health, public health methods, population health methods to prevention.
Hello, I'm Claudia Cooper. I'm, as you heard, a professor at Queen Mary University of London. Happy to welcome Seb recently as an honorary member of Queen Mary. And we've got a growing group interested in dementia and dementia prevention. I also co-direct the Queen Mary Policy Research Unit for Dementia and Neurodegeneration, which is doing quite a bit of work in this space. And you heard all about apple trees earlier, so lovely to be here.
Hi, I'm Joan Viskant, and I came into this slightly differently. I was working as a jazz musician, and that got your attention. And I got meningitis. I had a brain injury, and suddenly my brain didn't work anymore, and there was no help for people with a brain injury who had meningitis. So I started to help myself. The first thing I did when I got home from hospital was I went out into my back garden and I started picking rosemary from my garden. And I didn't know why, because I'd never touched it before. And I started making rosemary tea. And I know now that there's research being done on the benefits of rosemary constituents in Alzheimer's. So I started studying nutrition to help myself. And I also, because I couldn't get any help from the NHS, I couldn't get any help from the government, I found out that I could get help from the government if I got a degree with brain damage. So that's exactly what I did. I got my degree in nutrition, and then my parents got Alzheimer's, and I met people in Hammersmith and Fulham who found out that I knew nutrition. They helped me, and I helped them. I started giving talks on nutrition for over 50s, and then I helped people in a dementia group, worked with them to devise a menu because that's what they wanted. They had the agency to be able to tell me that they wanted to do this. We turned it into a game, and we presented them with a plastic-coated menu afterwards that went on their refrigerator with a refrigerator magnet. And we're going to follow this up in September to find out what went right and what went wrong. And I'm also working on a community project because if you're going to bring attention to nutrition, if you're going to bring attention to well-being in this community, it helps if you have a big project going. So we're developing a community space for people who have dementia and disability in Hammersmith and Fulham. It's called Jenny's Corner, named after a local neurologist who passed away, who was also a member of Hammersmith and Fulham Council. And we hope to have a medicinal herbal garden in Jenny's Corner, and also a sensory walk for people with Alzheimer's or disabilities.
Thank you so much. So we have some questions, but will be some space. I don't know if any of you have got a questions that want to pass on to us, or you're more than welcome to put the hand up somewhere at some point. So we have, if we can start off with maybe just could I ask you, Claudia, with an earlier presentation about your apple tree, you said when this encouraging prevention talk, the flexibility in support and approach was really, really important. So could you say a bit more about why the flexibility in support was really important, and also the capacity for change that was encouraged?
Yes, I certainly can. And actually, I can also, while talking about the importance of flexibility, because I was thinking about my answer to this question, which came somewhere, landed here anyway. How do we encourage young people from the Black community to talk about brain health? I don't know if anyone wants to own that question and say more about it. Yes? Okay.
I own it.
You want to feel free to add some of your perspective or why you're interested in that.
My name is Bettina Wallace. I'm an associate co-researcher at the University of Nottingham, working with this wonderful young lady. Dementia in my community is not talked about. We struggle to talk about dementia. I feel that if we start to talk about brain health from a young person's perspective, it may be that they will go home and talk to their parents. I have a 7-year-old daughter, 7-year-old granddaughter. And when I go, she goes, no, is your brain not working? She's 7.
Yeah.
Thank you.
It's a really interesting topic, isn't there? I think I can give a general answer and then just maybe reflect on some of the things that people have told me from the Black community. I think that we can all we all have more expertise in our own roots in the soil, don't we? And I think that to some extent, what we need to develop as a brain health initiative is something that is structured so that it helps everybody, something that can be tailored and flexible to different communities. And that is what we were very determined to do in Apple Tree. I don't know if you know Moise Roach, who's a Black dementia researcher in the space, who's very passionate about involving Black communities. And we went to a radio station for Black and Caribbean people in South London, specifically to recruit to the Apple Tree PPI group as part of our wider group, to bring in voices which are less often heard, to be part of that design phase that I talked about. And so we had very diverse voices in the room when we designed Apple Tree. I think perhaps one of the, obviously we looked at all risk factors, but I think it's particularly pertinent to look at diet, because diet is very culturally determined in terms of what it means, in terms of how it brings people together, and in terms of how excluding it can be if, for example, you use terms like the Mediterranean diet, or immediately, or the Nordic diet. It's immediately suggesting that it's not for some people. So we did a lot of thinking about what we call things, how we presented them, the photos that we put in the manual, making sure that it was a very inclusive approach, so that people that came to have the intervention felt that it was a space for them. Your question goes much wider than that, doesn't it? About how actually, I think what we're hearing is that we need to start a cross community conversation about brain health. And I guess each community has expertise in what works in that space of how dialogues can happen. I think that what we can do on a policy level is to enable those organisations to breathe and to have space and to have influence. I could go on and on, Seb, I feel I'm on your turn. You're watching.
I work with someone who runs the Hammersmith and Fulham Dementia Action Alliance, and she ponders on this a lot because she has some people in the Somali community in a very particular group, and she said that she was told that they don't talk about dementia at all, because if someone mentions that someone has dementia, then their child or their grandchild can't get married because it means that they're defective. So I don't have an answer for that, but how there needs to be this discussion to find out how this can be tackled.
I wonder if Seth would like to come in at this point. Earlier in your session, you're talking about this life course risk factors, and often kind of life course risk factors are very much kind of linked to your cultural values, customs, like traditions you passed on from your parents and grandparents, and often these cultural values are really difficult to tackle and change. So what are your thoughts?
Yeah, so I think there is precedent for community-based work which has really solid evidence that it can work. The challenge I think uniquely we have here is that brain health means everything and nothing, essentially. So, for example, there's a randomized control trial that I remember reading where they went to black barbershops in a particular community where hypertension, high blood pressure was a big problem, and they were able to say, we've tried sort of top-down interventions, we don't engage these groups. They go to the barbershops and they routed the intervention there. They worked with the community, effectively the barbers with the community leaders in this context, and they showed really impressive results. But high blood pressure is such a specific thing. It's so easy to explain to people, this is the risk of stroke, heart attack, take this medication. And I think one of the things we need to do in the academic space, the phrase brain health is kind of new, I think, in terms of being used regularly. I'm sure that you'll find mentions of it before. Alzheimer's Research UK, I think, had done some work in the last 5-10 years where they'd kind of come up with, or they'd found that this term was a much more accessible term for younger people to engage, rather than saying to a 20-year-old, you need to do this to lower your dementia risk in 60 years' time. We talk about a positive thing you can do for your brain health. I think it's quite a new space in that sense, and we need to kind of do a bit more around defining what it means. I was at a workshop last year it was in Africa, and we had people living with HIV-associated dementia, which is quite prevalent in that part of the world, and clinicians. And we asked them, what is brain health? And all of the clinicians came up with biomarkers. There was 2 different tables. The clinician table came up with biomarkers, and it's all about medical language that we could define. And every single one of the patients said brain health is psychological health, psychiatric health, mental health, as well as any kind of physical manifestation. And so it's still quite a new term, I think, in terms of brain health specifically, defining it, understanding what works for people, what it means to them. But in terms of the precedent of engaging communities to do community-based research, we know what to do. We've done it, just not enough of it. And part of that is because it costs a lot of money. Part of it is because it takes a lot of time. We need to invest. And I think there are communities there in terms of NIHR. A lot of their funding now is they're trying to fund things for 5 years, 3 years, so that you can take on staff. They try and do a lot more co-production. It's much more central. So again, returning to my point of optimism, I do think that there are reasons to be positive around that stuff, but it's just quite a complicated thing to do, so it needs to be invested in properly. And that's really good right now. I think we've got some kind of baby steps to define what that is.
Because you do work quite diverse groups, and sometimes you have to encourage who habit changes.
I just wanted to add, and this is a question for both of you as well, if that's all right, that one of the reasons why I wanted to bring the community garden into the mix was it was kind of very close to several charities, and this was an underserved community of the people with dementia, but also people with disabilities as well. And I was amazed at the reaction. We had a local business helped sponsor the start of the idea, and we had a big party for 200 people based on snails, believe it or not. And it was a huge success, and the local council got very excited over it. And I just felt that the whole community coming together. We had people with disabilities, people with dementia, actually on the tables, assisting people and talking and being part of the community. And it was such an amazing experience. It's not just about the diet. It's not just about the research. It's about finding joy in this group of people and being able to come together, able-bodied, because the place is a sports ground, and you don't really think of people with disabilities using a sports ground. So bringing together all these groups and normalizing it to some extent. I hate that to say normalizing because we don't really want to normalize it, but in the best sense of that. But I wanted to know from you two, especially in your project, what you think about bringing the community in to celebrate it. And also the publicity is great, you know, and to actually show this and to have publicity about it. It does a lot of the work for you, doesn't it?
Yes, absolutely. And that was very much baked into our Orii, the way that we set the groups up. So, for example, the way that we approached it, we designed and we manualized the African intervention, and then we went out to organizations to ask if they would like to co-deliver it. To give you one example, the Third Age project in North London were great supporters of ours. They did the pilot with us and they ran a couple of groups. And what happened was that we did all the administration, we did all of the research outcomes and so forth, but the groups were delivered by one Third Age worker and one of our researchers together. And the advantage of that was that there's lots of space in the intervention to sort of talk about how would you put this into practice. And of course, the charity was able to advertise all the other fantastic groups that they led, and people were able to reflect. Well, I really enjoyed it when we did the canoeing trip with the Third Age project was one example, and to talk about that and to encourage others to do it. And there were successful examples as well. And then at the end of it, the charity had also learned lots about mental health, and they'd also brought together. And when we did we funded to do this over a year, and to have monthly uni groups, but there was also the potential for them to continue that as something that they did as part of their planned program. And we did that across many different charities, and we're actually Harry tonight just putting together a new study to look at implementing this, and actually whether the community can be the deliverers, can be both of the things, and can take on much more of the project, because the way to keep things sustained is to gradually move them over and support for being entirely community-led. And implementation scientists that we work with talk to us a lot about the core components and the adaptable curriculum. And all the stuff like the specific diet, education, or the strategies that people use, a lot of that is the adaptable periphery. The core is that you bring people together, you talk to them about the best available advice, and then you give them space, safe space, to think together about the solutions and how they will support each other to meet goals. And of course, those community engagement is very important. Other part of Africa as well, which is changing things beyond going out and saying to your community, or walking football groups is one example. We need more accessible swimming, otherwise we can't do this stuff.
Can I just ask about, because it sounds like you did amazing, your team did an amazing job in terms of like sharing the ownership of like shared knowledge, and so the community actually owns that. This is not just something done by the researchers, but it's actually important to us, it's meaningful to us. And obviously your team managed to do this. Can you actually break down like what actually led to that ownership of knowledge? Like you obtained this knowledge together, and charities and communities said, actually this is really relevant to us now, which is like amazing mechanism to happen, isn't it? So can you actually explain to us like what made it successful, that process?
Well, I feel like I'm preaching to the choir, really, because it's actually about developing respectful relations at the beginning. I think what we were helped by, to some extent, was the pandemic, because the pandemic meant that none of us knew what to do. It was a great leveler in that we were meeting online and talking about whether we should continue with our work or whether we needed to pause. And nobody knew the answer. And somehow, I don't know if this is a translatable example, because I'm not sure I'm saying we ever want another pandemic, but there was something about all being in something together and facing something really difficult together that meant that we genuinely did develop equitable partnerships that endure and have gone forward. And certainly, as we suggested in the implementation study, everybody has jumped on board and engaged into it with us. I think the thing with NIHR Dementia Programme and with Apathy is that we've always committed from the outset to the funder that we will make everything freely available online. And actually, there is a monetized component to some things that can be a barrier, isn't there? But I do think that the lifestyle and psychological strategies which have good fortune to be nationally funded, it's really important to put that out there. So we say, you know, the evidence base for these interventions is based on having appropriate training and support, and we can offer that and we can recommend that you have that, but actually everything is here for you, take materials and choose yourself. We haven't actually got the Apatry website up yet, have we? Sorry, I'm just thinking that that's an intention. We have got them, if anyone's interested in the equivalent dementia care intervention, you can look at the nidusstudy.co.uk and you'll see that we've got all of our intervention manuals, and we have little short videos next to each of them to tell you a little bit about what's in them. So that's key.
Thank you, Claudia. We have got another question from the audience. What has been the biggest intervention to reduce prevalence of dementia over the time period in the last 10 years?
Well, so the question is, what I showed a chart where we saw from 1990 to 2010 there was a reduction age for age. An 80-year-old was less, about 10% chance of having dementia in 2010, and 80-year-old dementia had about 15% chance. What's driven that decrease? And the obvious answer is we don't know. In epidemiology, you can never track that when you're measuring across the whole population or big cohorts. You can't say for absolute certain what it is. But we do know from the work we've done which risk factors seem to be really clearly linked to dementia. Then we can therefore infer from changes in risk factors over that time which ones might have contributed. So we know that education improved a lot across the 20th century. By education, I mean access to education, and as a result, and also kind of societal attitudes, in particular towards girls' education, then you have an effect on average attainment levels. And the other big one is smoking prevalence. So if you track smoking prevalence across time in the UK, and then you can almost see kind of 10 very quickly after you see cardiovascular rates come down. Potentially what we're seeing is dementia rates. And then in the kind of 90s is when we started very primary care based approaches to an extent community approaches to try and managing cardiovascular diseases, hypertension, and high blood pressure. If you said 3 times, then presumably you can just use the medical word because you've now said it that much. High blood pressure, cholesterol lowering with statins, and generic kind of cardiovascular management. And again, really good evidence that those things are well linked. I think looking forward into the future, what we need to work on in a very medical space is
being able to use things we can measure in people as really confident markers of their brain health. So this is where I become non-public health and very valuable, but I think biomarkers which would allow us to really confidently say, actually, it is this intervention which has led to this improvement in brain health, which we now are confident will lead to a reduction in dementia rates. Again, as I said, all of this stuff is very kind of high level, policy level, population wide. You also need persons because no matter what we do, we are going to have lots of people. So not ignoring that bit. But I think the direct answer to the question is we don't know. Probably combination of better education, lower smoking rates, and better management of cardiovascular disease. And I don't want to end on a not positive note, but we do have to be careful because obesity and diabetes have really gone up for the generation now. Not just because we're detecting diabetes, but also because of backgrounds, rates of risk activity and that. And we may see some of those trends under who were to do that study again. So we really have to be active on those things to get worse.
Please be last.
Yeah, when I devised, when I helped devise the menu with dementia patients, I used I had to answer 3 questions. One is what's going on with people's health as they get older. Their body doesn't work so well. A lot of the functions don't work so well anymore. The digestion doesn't work so well anymore. Obviously, the brain doesn't work so well anymore. Maybe methylation doesn't work very well. They have trouble taking in the nutrients and throwing out the garbage, I call it. So I had to answer that, what would be useful for that. Then there is the problem with cortisol. And that's very interesting because people with Alzheimer's tend to have elevated morning cortisol as well. And how can we help that through nutrition? So what kind of a diet will help elevated cortisol, help to bring that down? Balancing blood sugar. So you reduce stress. Cortisol goes up with stress. Cortisol goes up if your circadian rhythms aren't working that well. And people as they get older have less melatonin. Melatonin works with cortisol to balance your circadian rhythms. So you have a lot of factors that are thrown into the mix, which you have to deal with, and you're not necessarily going to be able to help them completely to get better. But an easy fix is just balance the blood sugars, and that goes a long way to helping a lot of things. So you want easily digested food. You want to have more balanced blood sugar in your diet, and you want to make sure that people get nutrient-dense food as well. That means more protein, and that means any nutrients, all your different colors of vegetables, so you get all the phytochemicals in a form that they can absorb. You have to make it taste good, you have to make it look good, and you're not trying to fix everything. You're trying to increase the quality of life, not only of the person with dementia, but the carers and the family members. And if you think of it that way, because the person with dementia may not, we hope he or she has agency, some kind of agency up to a certain point. And that's why they count as in the whole thing. Their voice counts. But also, what about the carer? They're going to be the next person with dementia. They have so much stress. Cut down on the stress. So that's really important too. If the carers are eating right, if the family members are eating right, then they're going to want the people with dementia to eat right. It has to work together. It's not just one person. It's not just about what are we going to do. Just a little anecdote. my folks are in America. My mom was, the doctor wanted to put her into a hospice because she wasn't thriving, she wasn't eating, and she had dementia. And I went over there and I had to cook her a completely different meal than my stepfather. And I had to cook myself a completely different meal than all of them because we had different dietary needs. If you can make it as easy as possible, then you won't all go crazy, because it can be a horrible experience when you have to find some kind of joy. The joy for me was the fact that after a few days, she started getting better and her cognition became better because she was absorbing these nutrients. Now, maybe it's going to last a couple of months, maybe it's going to last a couple of days, but can you imagine having that bit of joy with your family, even for a short period of time, being able to experience that because they're getting nourishment, because their brains are getting nourishment? That's a very healing thing for everyone. So I hope that answered your question.
I was just remembering one of the apatry sessions when you were talking, which starts with making a good start. I think it's our first session. There's a little bit about diet in every session. It's quite eclectic. And it's about having a good start. What do you have for breakfast? And there's a little graph. We don't have many graphs in our manual, but there is a little graph about how blood sugars going up and down. The brain needs a consistent supply of glucose, and therefore a brain healthy diet is one with a consistent, essentially low GI approach. And it really speaks to a lot of people. And it's perhaps an example of how you can phrase things to be extremely culturally diverse by not actually being culturally specific. So you ask the group what they have for breakfast, and then you talk about how actually it can be very helpful to make sure that you have some protein and maybe some fruits and nuts. And but people bring the answer. It's surprising how little, if you have a group that get people talking, there's very little that you actually need to do in terms of advising, and telling people what to do is probably the least effective way of getting to change.
Can I add just one thing? Sorry, I forgot one very important thing, your microbiota, your gut. And that's another reason why you have all the different colored fruits and vegetables, because you have to feed that. Because what do the bacteria do? They talk to your brain. And where do you absorb all the nutrients? You absorb them through the gut. So if your gut environment isn't working, your brain environment isn't working. You know, if you're constipated, just think of all those toxins recycling in your brain. And of course there's going to be brain fog. Of course there's going to be issues with cognitive function. So very important to feed your bacteria.
So we'll have to take this outside, I think. But one of the things that really fascinates me, because it's been a real broad church apatry, working with sociologists through to people that are much more at the test tube end, shall we say. And one of the things that we were very clear that we didn't want giving a blood sample or giving a saliva sample to exclude you from the study, but actually 85% of our participants did. And one of the things that we're doing with the saliva sample is that there is somebody in East Anglia who's fascinated by the microbiota and how it was suggested to me that we could add a stool sample to the programme. This was suggested to me in the first week of COVID, at which point I thought I might die of stress, quite frankly, if we added a stool sample to the general scheme. And actually, you should never, I think, ask people to do something that you don't want to do yourself. But spitting into a test tube and popping it into a prepaid envelope is something that people were very happy to get on board with. And you can look at the saliva and you can look at the microbiology that grows, she says, probably without great expertise in that area. And the scientists looking at it sent me lots of beautiful, colourful pictures about how excited he was, about how actually you can see a lot about people's microbiota from these samples. but results to come as to whether our intervention has made any difference. But it will be helpful to know if it works, how it works, because it will be really important in terms of informing people what they can do, and also thinking about what we do to guide communities to change their diet for better brain health.
So we have two questions, one online and one from the audience. And before we move on to that, just what it has said, so if like in terms of like the diet, the gut health and cognition is associated, how do we actually tackle kind of population level knowledge dissemination or education?
Well, I think that 2 points. So one is that we, as I've said before, you have to have a multi-layered approach to that. So some of it is about educating people, supporting individuals. Some of it is rooted in community level. We talked about engagement, community leaders. And some of it comes from big policy leaders as well. So that is things like sugar levels, etc. And you need all of those things pulling in the same direction, I think, if you want to make change. There is an academic challenge in there, which is that translating some of what we just heard into really clear evidence is difficult. And then we also have this trade-off between, in academia, we want to study something really specific. So we take all these people and we make this one tiny change, something that we can actually measure the change in, so that we know whether it's worked or not. But in real life, our diets are mixed and we eat all over the place. And, you know, particularly some religious groups will eat in big kind of congregations together. Other kind of social cultural groups will eat in other different scenarios. And so maybe you're not always in control of what food you're being given, etc. So there's a big trade-off there. So you think, for example, about like 5 a day. Well, there was a phrase I had recently about eating multicolored foods, which was recently allowed. And so I was arguing basically we haven't really got past that. We've thought that 50 years, so we still basically think that. So we might have fancier names for it, but so I think there's a bit of a challenge in terms of how we. Sometimes the world wants us to be really precise and use all these fancy words and use fancy terms, but then the message is kind of the same. I do think there is one kind of public health principle though, which is that we can see changes in the diet of the population on a big level, and we do national surveys aligned to the commercial food environment. And if you are a manufacturer of a chocolate bar, your profits can only come from people. That's so if we have a basis for our food regulatory system, which is voluntary reductions, which is basically what we've had, particularly appeals to the kind of centralized political view of kind of individual responsibility, etc. All of the evidence says it doesn't work. All of the evidence says if you ask industry to do voluntary reductions in anything, you get almost no effect. Whereas we had things like the sugar levy, which was really carefully designed, mandated, and you see big reductions in consumer. And actually, like the sugar levy is a really good example, because if you go into a shop now, full fat Coke £1.10, Diet Coke £1. I've not removed any choice from you. You can still pick your sugary drink if you want. Other fizzy drinks are available. But then, you know, we haven't removed choice, but we see a massive change in consumer habits. We see a massive reduction in sugar intake. Well, not massive, but we see a very clear signal in reducing sugar intake in the service. And we haven't done it by removing people's choice, etc. But also we have had that kind of mandate to top up. So we definitely need that, but we also need to talk about community engagement. That's the multi-lines. But there is this trade-off, I think, between specific precision language and then the balanced diet, to vegetables, learning process. I'm not sure we don't resolve that, but there is a trade-off.
Thank you. Two questions. So I think one was from the audience. Would you like to ask?
Yeah, thank you. Probably don't need the mic thing quite.
Online.
Oh, okay, sorry. I've worked with the Alzheimer's Society, but having worked at Diabetes UK as well, I understand the obesity issue and the prevalence of high risk of dementia and vascular dementia. Particularly. What I wanted to ask, this is to everyone, but particularly you, about the nutrition side. Having worked in the sort of grassroots organisation in London, it is very difficult for a lot of communities to get access to fresh, colourful vegetables and fruits. So food choices are limited, especially if you're having to get them from a food bank. It's based on donations and what is available on the day. With that in mind, I know as an organisation we predict the prevalence of dementia to be increasing more, and that people with vascular dementia are probably going to be more at the higher end. So how it's lovely that those measures are in place, and when we talk about brain health and prevention, but I think in reality, the reality that I see in the ground level is very different. How do we then support all communities, especially those ones that are not from a privileged background where they can afford to go to a supermarket or a grocery shop?
Oh, that's a great question. And it's very close to my heart as well. What started for me during COVID was we all went out in the street because we couldn't be together outside the street. And my husband would play his trumpet, and everyone would gather around it like they were discovering something that was really they'd never seen or heard before, because it was the only real entertainment that we had. And what happened from that is we started a gardening group, and this eventually became what's starting as Jenny's Corner. And I've learned as we've gone along that people have extra plants for courgettes, and they have extra seeds, and they have extra this, and there's lots of help in communities to find spaces where you can have community gardens. You can get a huge amount of food from a community garden, and it brings the community together. You grow together. You can get outside resources in to help with it. You can get people from the government coming in to show you how our charities, I think there's a community garden association who will come and help you build your community garden. There are places where I hope I'm not saying things that is going to be in one of the next lectures or something about gardening. But there are groups of things like men's sheds where they say, oh, well, we can build this and we can build that. And suddenly you have places. You can build a little garden in a window box. It's amazing how much food you can get. I mean, just the other day, someone said, oh, I have extra basil, I have extra parsley, I have extra peppers, and I haven't had to buy anything this year because it was all given to me. So is that possible for your community?
That's fine. In all honesty, it is very challenging in some parts of London, for example, Haringey. I know communities like in Tower Hamlets, they have it's not sustainable way for them to eat and live. I think there needs to be a wider initiative than that to make it. And it goes back to education, going back to nursery or primary school, how important eating good meal is and how to do gardening, encouraging all of that. But in the communities I work, I'm being really frank, that isn't. A lot of people are probably out working those hours instead of investing in gardening and taking that time out. So it's not something that is easily available.
Yeah, I was just going to say, a friend of mine, Alex Laird, she's a medical herbalist, and she runs a charity called Living Medicine, and she'd go around to different underprivileged groups or, certain communities, and they would cook together, and she would point out the values of different foods that were really inexpensive and really accessible, and she would discuss their value. So maybe it's worth talking to someone like Alex, and we can talk afterwards.
Yeah, let's do that.
Yeah, because it has to be possible. I'm one of these people, I believe it's possible, and look at, we're a community here, we can all help.
Okay. Yeah, I mean, as a psychiatrist in Tower Hamlets, I recognise those contexts. I think it's a very how you support people in food deserts, which is eventually what you're talking about, isn't it? Is something that there has been a lot of thought in, as you will know, things like the breakfast clubs that have run very successfully in London schools. And a lot of it is just about the harsh financial barriers, isn't it? And actually the fact that if people have the food, in that case, you know, giving breakfast cereals to children that had some protein in them, which made question obviously as to how they learned. I think that certainly we were very conscious of that in our country. We were very conscious, for example, of providing cheap, so our one-off food delivery to support the recipes and the food ideas that were tried. There was more debate about what went into that than anything else. I think though at one point we were going to call the qualitative paper not avocado, because that's what somebody shouted. You know, so it was about frozen things, but also, you know, appreciating some people don't have a freezer. So real tin to keep the prices really low, trying to do things that people might want to continue that weren't sort of culturally specific. I suppose just one final word, because I think there's a lot that people want to say on this, is that the thing about secondary prevention is that these are people that are already coming to services and asking us, what can I do to help my memory? And we have a responsibility to come up with the most effective ways of helping them. And essentially what Appletree did at the most basic level was it brought people together to discuss ideas. And if you do have finite options, discussing those finite options and what you've tried out and what might work for you in your setting is actually sometimes quite empowering and helpful. And often people came to the sessions and never came up with any goals for themselves. So they just wanted to come to the next session, they wanted to meet up with people. And they didn't take anything from the dietary recommendations, but maybe they took something from the social or the well-being or getting help from the doctor for their blood pressure. But yes, it goes to the root of a lot of social problems. It's not easy.
Morning. So there's two things I'd like to say. The government at the moment is negotiating, isn't it, with supermarkets about these end of aisle things, and 3 Red Bulls at the price of 1 to say it's got to be green vegetables, healthy foods. It's complicated because of the cultural aspect, but that's a start. But as Seb said, at the end of the day, supermarkets are in for money, aren't they? For little Aldi or Waitrose. So we have to be careful with that. The other thing I'd say is that there is a project called Inflame, you might have heard of. It's a 10-year program looking at what we can do with diet to hit multi-morbidity. We have to think beyond dementia, I think, because it's often closely linked. And we've deployed AI in 10 billion data sets, and I haven't got the answer, because my job in this in 5 years' time is to come up with what is the perfect design, intervention, and diet. And you hear lots of maths people going round and round and round. The cohort data we've got are actually rubbish. They don't collect data properly, data sheets. So it's tricky beyond the Mediterranean diet to know what to say. But I think it's also about shaming. With the InSTEM group, we talked about not shaming people, quantity. We may not have healthy stuff, but having less of something unhealthy, that's not a shameful thing, because I can't afford the blueberries. And in InSTEM, in Inflame, we started off with, it's all about blueberries. We just need to deploy blueberries everywhere. It's anti-inflammatory, that's what it's about. And it's not as simple as that, because you can have too much anti-inflammation discovered. You can be on loads of anti-inflammatory drugs, loads of blueberries, and you're killing yourself through shutting down the inflammatory system, potentially, and the immune system collapses. But there's more work to do, I think, from my perspective.
I am aware we are nearly time to close this session, and I just wonder if you've got just one each, for instance, take-home messages from the panel members, would you be happy to send?
One thing to bring up. Well, so I think I'm going to stick with my theme of we all need to collectively advocate for balance, and we need to work out which bits we know we could do better at, but don't get the attention that they need. So that means we need to empower people for education without blaming them. We need to engage with communities within the resources that we have and meet people where they're at, which is effectively, I think, that's to your questions. We have to meet that community where it's at. It doesn't make sense to go down. I did some work with the local mosque and Peterborough, and I was looking at, I walked in and talked about a Mediterranean diet. It talks about taking it instead of 5 chapatis, because that was actually the. So you've got to meet where they're at in the communities, and then we also need much more attention at the policy level on the food environment, etc. So I think we've got a balance across prevention to care. We've got a balance across individual community population.
Yeah, I think my take home is about diet as well. I think, in fact, we were talking before we started, weren't there? There are lots of reasons not to talk about diet. As soon as you talk about diet, there's a risk that, you know, if you get it wrong, you can be exclusive. It's very difficult because you come up against financial barriers, you come up against supermarkets, you come up against vested interests. And as a doctor that trained in the sort of 90s, I have to say, diet wasn't really mentioned a whole lot at medical school. It might be different now. Still no. It's all about the body, what you put in. We should think it might have had a bit more there. And certainly when I was it's a bit different now, but when I started as a dementia doctor 20 years ago, people would come in, and many of you will know that if you have Alzheimer's, you very often have a sweet tooth. So not commonly, carers will say she only eats sweets and crisps and nuts and cakes, and not sweets and cakes. Doesn't matter. And I would hear my consultants when I was junior doctor saying, no, so long as she's getting the calories in. And of course, we wouldn't say that now, because I think we realise that it may be difficult, it may be hard, there may be barriers. We don't want to blame people. Obviously, if that's all you can eat. I mean, I went through whole pregnancies where I could only drink Lucozade, quite frankly, because nothing else will stay down. So I do know sometimes there's a finite amount you can do. But actually, I think we do have to hold on to the truth that diet is probably a big part of the solution, not alone.
Oh, I'm glad you said all that. My take home would be find joy, because food is joyful, community is joyful, sharing is joyful, making your life easier by finding a way to prepare food so that you're not working all the time and you can actually enjoy it yourself when you're looking after someone else. That can give you joy as well. So there are lots of ways to find joy in the context of dementia. And I think that we can forget that. And food is an obvious way to joy and sharing. So please focus on that. Focus on your health and the health of others, and you can find that joy.
Right, so this is the end of our Q&A session. So thank you very much for the panel members.